Yes, I hear
Everyone
you.
hear me? All right. Well, perfect. We'll get started. Everyone, thank you for being on the call. I feel honored, number one, to be asked to speak with all of you on this really important topic, and then number two, that you would take time out of your schedule to listen to me for an hour. So thank you on both fronts. As Haley suggested, we're going to talk a little bit about infant safe sleep in the home setting. And as a physician at Nationwide Children's, I tend to focus more on modeling safe sleep and educating families in the hospital setting, but certainly have an interest for doing this as well in the home setting and outside of the hospital, because I almost feel that's more difficult. We have the relatively controlled setting in the hospital, whereas I know it's sometimes a bit harder to take those good practices outside of that controlled setting. So to start, I don't have any disclosures. I have no relevant financial relationships. I do not intend to discuss an unapproved or investigative use of a product or device. So we'll get that out of the way. As far as what I hope to pass on to you all today, as far as objectives, I would like you all to come away with understanding the risk of unsafe sleep and the relation of infant safe sleep to infant mortality. We will go through some reasons that families choose to adopt unsafe sleep practices. And then my goal is to help you become familiar with some best practices and ideas and ways to empower families to practice those appropriate infant safe sleep behaviors in the home setting and outside of the hospital. So let's get started. All right, so pardon me for a little bit. I'm going to do what may be a little bit of review for some of you, maybe new information for others, but hopefully we'll get some learning out of all of this. And so I wanted to start off and make sure that everyone was on the same page with this by going through very quickly, what is an infant mortality rate in the first place? What are we talking about? So by definition, an infant mortality rate, which I'll be referring to multiple times in this presentation, is the number of deaths in children aged 1 year of age or less, infants, divided by the number of live births in any given population. This is typically reported as a number of deaths per 1,000 live births. So, for example, 4.0 deaths per 1,000 live births, or 4.0 can be a country's or state's or what have you infant mortality rate. And we'll go through national and local data here shortly. This is really important because it is often used as an indicator of health and well-being of a nation or country. Other countries in the world look to different countries for infant mortality rates. Unfortunately, as you can see in this graph, we're not doing very well in the United States. So you'll notice the abbreviation OECD up at the top. OECD stands for the Organization for Economic Cooperation and Development. Most of these countries on this list are OECD countries and are defined as mostly developed countries. They have a high economic income. They have a shared goal of promoting democracy in the market economy. As you can see, however, we're close to the last for infant mortality rates whenever you compare to all of these other developed countries. Our infant mortality rate in 2015 was 5.9 per 1,000 live births. This is one of the last years this was calculated. So certainly we still have a ways to go to lower our infant mortality rate compared to other countries. Whenever you zero in a little bit and go to Ohio, which will be on the next slide here, you can see the problem is still very close to home. I mentioned the infant mortality rate in the United States was 5.9. Here in Ohio, our infant mortality rate taken during the same time frame was 7.2. And actually, we are one of the worst in the United States as far as infant mortality rates. Overall, we are ranked 39 out of 50 for a statewide infant mortality rate, so the 11th worst. Whenever you break this down into babies born to black mothers and babies born to white mothers, babies born to black mothers have an infant mortality rate of 47 over 50, so we are the fourth worst in the country. Babies born to white mothers, we are 38 over 50, or 12th worst in the country. So certainly we have a ways to go before really kind of bumping ourselves up in any graphs or data compared to the rest of the country. To compare this, the United States has an infant mortality rate that is similar to Serbia. our overall Ohio infant mortality rate is similar to that from Kuwait, and our Ohio black infant mortality rate is similar to that seen in Syria. So again, countries that aren't necessarily as developed as ours aren't really doing any better than we are. So again, we have a ways to go. This graph will compare infant mortality rates in both the United States and Ohio from the 2 decades in 1990 through 2012. And you can see in this graph, while infant mortality rates in the United States and Ohio have dropped since over those 2 decades, you can see there that toward the past 10 years or so, the infant mortality rate for the United States has actually declined at a higher rate than the Ohio infant mortality rate, which tells us that the rest of the states in the United States are doing their part catching up, whereas Ohio is kind of stagnated almost over the past several years. So how does this relate to safe sleep? Well, so infant safe sleep is unsafe sleep conditions and sleep-related deaths, which we'll go through, are a major cause of infant mortality in the United States. It's actually one of the leading causes in infant death. In comparing ICD-10 codes, which is what healthcare providers use to bill and code for diagnoses seen in the healthcare setting, this was one of the leading causes of infant deaths, second or third, only to congenital malformations and chromosomal abnormalities and disorders related to short gestation and low birth weight, which is often what prematurity gets coded as. So sudden infant death syndrome, and then I put in parentheses accidental suffocation and strangulation in a bed, were also right up in the top 5 codes seen as leading causes of infant death. So let's talk a little bit more about the history of safe sleep. Several of you might remember that back in 1992, the American Academy of Pediatrics recommended that all infants should sleep on their backs or sides at that time to reduce the risk of SIDS, or sudden infant death syndrome. This statement was revised in 1996 to take out the sides part. Pediatricians had realized by that point that sleeping on the side was an unstable position and that most of these babies rolled to their stomachs. So in 1996, this was just updated to all babies should sleep on their backs. In 1994, the National Institute of Health and the National Institute of Child Health and Human Development launched the Back to Sleep campaign, which some of you might remember as well, to spread this message and the idea that the babies should be laid on their backs to sleep for every sleep. And so revisions have been made roughly every 5 years to these safe sleep recommendations based on new and the latest research. So since 1992, as a result of this campaign and the safe sleep recommendations, SIDS deaths, or the sudden infant death syndrome deaths, have decreased. However, other causes have increased or come out as SIDS has declined, and I think some of this is just better coding and better diagnosing. But regardless, we have seen an increase in suffocation, asphyxia, strangulation events in bed. And so overall, our sleep-related infant death rates over the past several years have really plateaued quite a bit. So next slide. And you can see that illustrated in the graph right here, so sudden infant death is the red line here, and you can see this is very precipitously dropped from 1990 to 2000, and then even still an ongoing drop over the past 15 years. And the green line, accidental suffocation and strangulation in the bed, has slowly increased over the past 15 years. And so you can see that over the past 5, 7, 8 years, the yellow line, the combined SUID rate, and we'll talk about SUIDs here momentarily, has really not changed a whole lot. So next slide. So getting into definitions, I just mentioned this term SUID, which might be a new one for some of you. A SUID stands for sudden and unexpected infant death. This might be unexplained or explained after a case investigation. And so what a case investigation involves is a coroner going to a scene investigation, an autopsy of the infant, a review of any clinical history. Was this child seen in a primary care office? Were they followed by subspecialists? Had they been admitted to a hospital setting recently? And so these might be, again, explained or unexplained. So the suffocation that I mentioned, the asphyxia, the entrapment, traumas, ingestions, infections, and then kind of a host of other things. Whereas SIDS, which is considered a sudden unexpected infant death, is by definition unexplained. And again, this can only be rendered a SIDS death after one of those thorough case investigations that I mentioned. So next slide. So to be honest, no one really knows 100% sure what causes SIDS. Again, these unexplained sudden infant deaths. We do see that the highest risk at 2 to 4 months is 2 to 4 months of age of the infant. This likely represents some critical time in their brain development. And then paired with some kind of intrinsic risk factors, there potentially might be some genetic factors that scientists are working to discover. There might be prenatal smoke or drug exposure, some kind of brain or brainstem abnormalities. Again, those are being studied, as well as a few other factors. And then some intrinsic risk factors. And many of these intrinsic risk factors are the same ones that that lead to the explained infant deaths. So the soft and loose bedding, the cigarette exposure, the prone sleep position. So whenever you combine all of these, there will be some infants that do have a SIDS or unexplained infant death. But more often than not, these deaths are being more often explained than not anymore. We are seeing fewer and fewer deaths coded as SIDS or the unexplained deaths, and more deaths coming out with an explanation for their cause. So in Ohio, the Ohio Child Fatality Review comes out every year and will go through infant deaths over the past year and then the past larger time period. So the last one came out in the fall of 2017. We should expect a new one anytime. And so they looked at deaths from 2012 through 2016. During that time, there were 714 sleep-related deaths in Ohio. And whenever you break this down by week and by year, this is between 2 and 3 sleep-related infant deaths per week. And if you thought about it even further in terms of education and the impact that these babies could have, this is enough to fill 6 to 7 kindergarten classrooms every year of babies that have died of sleep-related deaths, depending on how many kiddos you think should be in a kindergarten classroom. But again, a sizable amount. Sleep-related deaths account for about 15% of all infant deaths in Ohio, and black infants and male infants are disproportionately affected. I thought another interesting statistic put out by the Ohio Department of Health, sleep-related deaths in infants occur at a higher volume than do child deaths of all ages from automobile accidents every single year. Every single year we have a higher number of infant sleep-related deaths than automobile deaths, which I thought was staggering. So again, I mentioned in a previous slide, most of the deaths that we see in infants are from 2 to 4, 1 to 4 months of age. This seems to be that vulnerable period that I talked about. Certainly we do see infant deaths in other time periods, but that younger period really seems to be the most vulnerable. So next slide. So what to do about all this? In 2011, I mentioned previously that the Ohio AAP had done these recommendations and revisions of those every 5 years. And so in 2011, there was a major change, and the AAP Task Force on SIDS expanded its focus toward creating a safe sleep environment for all infants. So not just those SIDS cases that we were discussing, but all sleep-related deaths, those strangulations and suffocations. And so 2016 was the same with some ongoing recommendations. They did come out with 18 recommendations, actually, directed at parents, healthcare providers, researchers, and health policymakers. We are not going through all 18 during this presentation, so you can breathe a sigh of relief there. But we will kind of hit on the few that are kind of the most, I guess, important that you should be educating and teaching and trying to model when possible with the families that you see outside in the community. So to distill this down into the bare bones, and if you remember nothing else from this presentation, maybe remember this. think about the ABCs, quote unquote, of safe sleep. And the A stands for alone. The infant should sleep alone in a separate sleep surface for every sleep. That includes nap time and nighttime. And oftentimes, a lot of parents, when I see them, will say that yes, we put them back to sleep in their crib every night for sleep. But whenever asked, well, where do they sleep at grandma's? Where do they sleep at the babysitter's? It's sometimes a little bit more dicey. Sleeping in grandma's bed, sleeping somewhere else, it's not as safe. So babies need to be sleep alone every time, on their back. And I think most families know this by now. Infants should be put on his or her back for every sleep. So not the side, not the stomach, but the back, again, for every sleep. And then C is for crib. Infants should be placed in an empty crib for every sleep. And so that means a crib or a pack and play or a bassinet, something of their own that doesn't have any stuffed animals, pillows, diapers, wipes, all kinds of things that we've seen. I'm sure you've seen as well, but an empty crib for every sleep. So this will be the slide where I will warn you, there are several pictures throughout the next part of the presentation that are taken from the Cuyahoga County Coroner's Office. These are scene investigations that I had mentioned a little bit earlier, pictures that they have taken. So these represent, these are dolls obviously, but they represent real babies and real patients that they were called to do scene investigations on. And so please take these to heart and maybe think about these whenever you're counseling, whenever you're talking to families, because these scenarios do truly happen. Here in Ohio, all around. So next slide. Next slide. It's not advancing on my computer. Maybe I'll just, oh, there we go. Okay, perfect. Perfect.
There we go.
Okay, perfect. All right. So again, going through a few of those 18 recommendations we talked about. This one I suspect you all are familiar with. Again, this has been around for a few decades. This is the back to sleep every time. You'll note that I put level A. This is as strong as a recommendation that the AAP can put out. This is the top. So this is very evidence-based. Babies should be sleeping on their backs until 1 year of age. Again, we no longer recommend side sleeping. It's not safe and should not be advised. And this is for all sleeps, both nap time and nighttime. Next slide. All right, next slide. So maybe we're having issues advancing slides, so I will just talk about the next slide. One question I often get from parents is, well, what if my baby chokes, or what if they spit up a lot? Won't they aspirate, or won't they choke on their own secretions from if I put them on their backs? And the answer is no. So hopefully we can get the next slide put up here in a minute, and I can show you pictures that I normally present to families to kind of help them feel a little bit better whenever they are laying their babies on their back to sleep. So we'll get those pictures pulled up here momentarily, but
I am working on the technical end. I'm trying to figure out what our delay is.
Oh, goodness. Well, God love you. Let me see here.
Thanks, everyone, for your patience. I'm going to see if I can switch Wi-Fi and hopefully get something to move a little better. So just one moment.
How about this? I know we said that we were not going to have any questions in the meantime, but since we have a little break here, if you have any questions right now based on anything I've talked about, please chime in. If we get the slides going here quickly, then, oh, there we go. Perfect. All right. Well, again, we will try to answer as much as we can. Very good. Thank you, Haley. So talking a little bit, again, a lot of parents' concerns is will my baby choke if I lay them down on their back? What if they spit up? And so these are two pictures that I present to families to kind of help ease their concerns with this area. So you can see the picture on the left is whenever a baby is put down on their backs or supine. And so you can see in this picture that gravity, gravity helps us a little bit. The trachea is on top, the windpipe, and the esophagus, or the food tube, as I tell families, is on the bottom. And so that you can see here, if a baby has spit up that goes from their stomach up to their esophagus, gravity will help us a little bit here and will kind of aid in having a less likely chance of having any spit up or any aspiration go into that trachea or the windpipe. Whereas if you flip the baby on his or her stomach and so place them prone, you now have stomach secretions or spit up or what have you going into the esophagus, and then gravity very easily helps take those secretions down to the trachea and then into the lungs. So it's actually more common that babies will have aspiration events or spit up issues, spit up events if they are placed on their stomachs because of this gravity issue. So again, it's my understanding we will make these slides available after the presentation. So these are certainly pictures you could use with families that have these similar concerns, because we certainly hear a lot about this in the hospital. Okay, next slide.
Which hopefully should be appearing.
Oh, perfect. All right. So the second recommendation, correct sleep environment. Again, this is a level A strong recommendation from the AAP. This needs to be a firm fitted mattress with a crib sheet, and the mattress needs to fit the cribs. And so all cribs, including portable cribs, play yards, the pack and plays, the bassinets, should meet current safety standards. We do recommend new cribs. I know this can be a financial hardship for families, but you can see in the picture why we recommend those new cribs. These do meet the safety standards. There are no missing parts. They will have intact hardware, appropriate slat spacing, which is about the width of a dollar bill, and no drop rails. And these have been kind of outlawed, not sold for about the past decade. Car seats and sitting devices are not recommended for infant sleeping anymore. We hear a lot of parents that will keep their babies in their car seats to keep them elevated, and will place the car seats in the crib. That's actually an unsafe sleep environment, and we have had infants die from getting in an unsafe position or rolling out of their car seat or the car seat toppling over. An interesting statistic here, if families place their babies on their stomach, and there is kind of this soft bedding, the unsafe sleep environment, the incorrect sleep environment, there is a 21-fold increase in the sleep-related death rate. So it really, sleep-related death risk, So it really is a huge risk with not having a correct sleep environment. I'll talk a little bit about deaths in sofas and chairs. There was a study done a few years ago kind of comparing risk for suffocation of infants sleeping in cribs versus adult beds versus sleeping in other locations. And so the study found a lot of things, but a few things I thought I'd mention were for babies that slept in sofas and chairs and were found deceased, entrapment and overlay, so someone laying on top of them or something lying on top of them, were the most common dangerous issues. The average age of these babies that died was roughly 3 months, and the majority of deaths occurred when the infant shared with the surface with another person. And again, we'll talk more about deaths in sofas and chairs versus adult beds versus other places, but both are pretty risky. So shifting to deaths in adult beds, entrapment here was the most common dangerous issues, getting babies in a position to where they were trapped, couldn't get out, and then had a suffocation event. And so as you can see in this picture, 30% of the babies found in this situation in the adult bed were between the mattress and then a headboard or footboard, and then half of the babies were found between the bed and the wall, and this picture is between the bed and the dresser. So again, this can easily happen, kind of underscores the issue with babies sleeping in other places besides a crib. So going forward. Here locally in Ohio, the Ohio Child Fatality Review that I had mentioned, when looking at those 714 sleep-related deaths we talked about a few slides ago, Bed sharing or sharing a surface was reported at the time of death in about 53% of the reviews. In those reviews, 48% of those were with a supervisor who identified themselves as impaired at the time of the accident. Most of these reported they were impaired by sleep, they were exhausted, not surprisingly with a new baby, and then 13% impaired by alcohol or drugs. For 11% of those infants identified as bed-sharing deaths, the adult did fall asleep while feeding the infant. There were similar numbers of deaths with parents both bottle feeding and breastfeeding, so those were similar. And then in 35% of all of the space sharing or bed sharing deaths, there was a secondhand smoke exposure present. So again, these kind of highlight the big risk factors, and again, kind of going back to if possible, really stressing that babies need to sleep in their own correct sleep environment, a crib. So next slide. Okay. Recommendation number 3, everything out of the crib. And again, this is a level A recommendation. And this includes pillows, quilts, comforters, blankets, sheets, any other soft surfaces. So even if a baby isn't placed supine on their back, having the things in the crib will increase the risk of SIDS 5-fold. And I will tell you that as a hospitalist, we see issues with this all the time, even in the hospital settings. I know this is a big issue, not just for you all, but for what I see as well. We see things in our cribs in the hospitals all the time, diapers, wipes, blankets, toys, all kinds of things. So this is an issue I think we're all struggling with. We do now avoid the use of wedges, positioning devices, and bumper pads. Ohio, within the past year or two, has joined the state of Maryland and the city of Chicago in banning the sale of bumper pads. They are no longer found here, although parents can certainly order them online. You won't be seeing them in the Targets or the IKEAs. I used to say Babies R Us, but not so much anymore. But you won't find them in stores locally, but they still can be found online. So parents might still have them and should be educated. So talking about objects in the sleep environment. Again, a study was done a few years ago which looked at risks for risk of sleep-related deaths for older and younger infants. They found that in the sleep-related deaths that they studied, there was an object found in about a third of the deaths. The deaths in the older infant group, and that was identified by infants about 4 to 5 to 12 months of age, were more likely to be associated with objects in the sleep environment than were infant deaths in the lower age group. And I suspect this is largely because these older infants were rolling, moving about in the crib, and then somehow got their airway occluded by a pillow, a blanket, a toy, what have you, whereas younger infants aren't rolling as much. But recognize that this can be a risk in any infant. Most commonly seen in this study were blankets, and those were present in about 25% of the infant deaths, and then pillows, about 20% of the infant deaths. In Ohio, this trend has also played out. There were about 175 sleep-related deaths in crib and bassinet in that 2012 to 2016 time frame. 120 of those, or about a quarter of those, had the items in the crib, and the most common as well were blankets, comforters, quilts, and pillows. Our next recommendation, number 4, yes to room sharing, no to bed sharing. And I know this is very controversial, and we'll be discussing a little bit more on this in a little bit. But sleeping in the same room, but not on the same surface, a different surface, will decrease the risk of SIDS and sleep-related deaths by 50%. So really a huge decrease because it's less likely to result in suffocation. Bed sharing may increase the risk on the other side of overheating, rebreathing exhaled gases, any kind of airway obstruction or exposure to tobacco smoke if whoever is in the bed with the baby has smoked. And then an increased risk of suffocation, especially if sleeping on a couch or in an armchair. So overall, not the most safe procedures, and you can see those pictures below. In Ohio, again, going back to that child fatality review report, 53% of the sleep-related deaths during that 5-year time frame I mentioned were bed sharing. 70% of those were with an adult only. 15 or so % were with another adult plus a child. For the bed sharing deaths, 48% of time the parent reported themselves as being impaired. So next slide. The question I often get, when is the infant most at risk? And the short answer is, of course, all the time. But we do know from studies that there are some increased risk factors. And so these are listed below. In short, the very young infants, less than 4 months of age, if the infant is preterm, if there is a current smoker in bed, and again, getting that secondhand smoke exposure, bed sharing with someone who uses alcohol, illicit drugs, pain medications, any kind of other kind of altering drugs, bed sharing with another child or multiple other people in the bed, or pets, which I'll add, or when placed on a very soft surface or surrounded by soft bedding. I have known families that have put their babies down on air mattresses or water beds, and these are extremely unsafe, even more so than the regular mattresses. I will also add obesity to this, can be a risk factor as well. All right, getting down to the last few we're going to discuss. So the fifth one, avoiding smoke exposure, or level A recommendations. This should really be counseled on avoidance during pregnancy if you are with families during that time, and after an infant's birth. The risk of SIDS is higher when the infant bed shares with a smoker. I suspect this is not new information for any of you. The SIDS risk does increase with the number of cigarettes smoked per day. So if mom does smoke 1 to 9 cigarettes per day during her pregnancy, there is a 2 times greater risk of the baby dying of SIDS once it's born in the first few months, and then a 3 times greater risk with 10 or more cigarettes a day. There have been studies that look specifically at the association between tobacco exposure and SIDS. These studies estimate that up to 1/3 of SIDS or sleep-related deaths could be prevented if all maternal smoking during pregnancy were eliminated. So this is huge, and obviously a big risk factor, and something that's being studied more and more over the past couple years. So I expect more research to come out in this area. So pacifiers are good. This is also a level A recommendation. Studies have reported a protective benefit against SIDS and sleep-related deaths, and this is even if the pacifier falls out of the infant's mouth. The exact mechanism is unclear, but scientists suspect that there are some lower arousal thresholds. There might be some kind of good modification of autonomic control, improved airway patency, so a number of potential different good causes, but no one is really sure. There should not be strings or stuffed animals attached to the pacifiers. I think the brand name for many of these is Wubbanubs. I'm sure there are other brand names. I have walked into a hospital room when seeing patients at the hospital, and I've seen babies' noses occluded by pigs and turtles. And so this does happen here as well, and it is a very real risk. So really counseling families to get those things off of the pacifiers. There should be no toys or any kind of developmental positioning devices to prop the pacifier either. It should be allowed to fall out whenever the baby goes to sleep or when it needs to. Of note, finger sucking is not protective against SIDS. I get asked that periodically as well. All right. Breastfeeding is good. Again, I'm sure that's not news to any of you. It is a level A recommendation. Breastfeeding for any duration is associated with a 60% SIDS risk reduction, and this risk reduction goes up to 73% for exclusive breastfeeding greater than 6 months, which is a big bonus. A recent study in Germany showed that exclusive breastfeeding at 1 month cut the risk of SIDS in half. So again, we can see good benefit even from small periods of exclusive breastfeeding. So really counseling your parents and moms to do this as possible, and the fathers and the family should be supportive. So, next slide. Next slide.
I am, again, working on potential technical, but we're coming.
Okay. It's all right. We can do this. So I'll talk a little bit. The next part of the presentation is going to be called Spreading the Message, and really identifying ways and suggestions and ideas and going through some studies of potential ways to provide messages to families, tips you might be able to use, new data that's coming out. And so we'll kind of go through that and then hopefully have some time for questions. Perfect. All right, we can go to the next slide as well. Perfect. All right. So talking about spreading the message and giving advice, there was a study done and published a couple years ago in Academic Pediatrics, and this is a survey of postpartum mothers 2 months after delivery. And so these mothers were enrolled at the time they gave birth to their babies. They went home for a few months and then got called on the phone a couple months later and asked to be surveyed. And so the survey went through questions regarding breastfeeding exclusivity and how often and how much, as well as sleep-related issues, bed sharing, room sharing, or is the baby in a crib, what's going on. And so the study found that moms who bed shared were 2.5 times more likely to be exclusively breastfeeding. Of note, there was not a strong question on room sharing at the time, so I would be interested to see some of the data on that. The encouraging thing that I take away from this study, however, is that 60% of exclusively breastfeeding moms room shared. They did not bed share. They room shared. And so this tells me and tells others that it is possible to both exclusively breastfeed and room share, again, having that baby in the bassinet or pack and play or what have you, the crib right next to the bed. It is possible. The other encouraging thing that I've taken away from this study is receiving advice on room sharing and breastfeeding increase both behaviors dose-dependently. So the more advice that parents got on both of these good behaviors, they took to heart, and they did. And so I think giving this advice, will not cause breastfeeding rates to go down, will not cause bed sharing rates to go up, because parents are listening. And so I want you to take that to heart whenever you're out advising and counseling families, that they are paying attention to what you're saying, and what you do say will matter. So this next slide will also talk about the impact of health messages about safe sleep position. So this is another one of those studies to where parents were asked in the postpartum time period if they would take surveys shortly thereafter. And so they agreed to take some surveys, and then they agreed to have some education on safe sleep and SIDS. And so they were African American mothers, and they were randomized to receive either very standard messages on safe sleep to reduce the risk of SIDS. And so primarily these messages just talked about SIDS, and that was it. And then they also, the other half were given advanced kind of enhanced messages about safe sleep practices to prevent SIDS, not only SIDS, but suffocation, asphyxia, entrapment, etc. Kind of a more detailed type picture. And what they found for both of these is that there was a decline in sleep positioning over time, even with the parents that received the enhanced messaging. However, they did find there was a very high parental knowledge of recommended sleep position. Overall, it was just the question of how could parents do this. And so the reasons for infants being positioned and placed elsewhere, a lot of parents didn't think that back to sleep and the soft bedding, et cetera, really did prevent against SIDS or suffocation. They thought it was safer if the baby was in bed with them. They were worried about the fear of choking, as we talked about, and they thought the baby was more comfortable in bed with them, perceived infant preference. This is the slide here that it's encouraging to me. Mothers were more likely to place their babies to sleep in the supine position in a safe sleep environment if a nurse had discussed safe sleep with them. However, they were less likely to do this whenever they had discussed things with the father and with friends. And so I fully understand and I agree that this is really difficult because parents are listening to a number of different sources, including you, nursing staff, healthcare providers. But please be encouraged that they are listening to you. And so what you say and what you counsel does matter. And so please don't stop. This is so very important. This work is so very important. And I think this study does show, even though there was a decline, that what healthcare providers speak does make a difference. So evidence for successful behavior changes. The study that I've listed here went through 5 categories of safe sleep interventions and how effective these are. We're going to talk about the 2 that relate, I think, most to our fields, the health field, and the work that you all do on a daily basis. So talking about health messaging. The study looked at health messaging and different ways of getting the message across and trying to figure out what resonated the most with families. And so they found that these sound bites, these little bits that you see on Spotify or at the bus station or on the radio, are often pretty inadequate and not very personalized. And so they found that these longer sessions, even a few minutes, were likely more appropriate. And so they looked a little bit further, and they tried some interventions in Washington, D.C. So next slide. And so in the Washington, D.C. study, they did 15-minute sessions with very small groups, 2 to 3 to 4 moms only. And these focused on individual parental concerns. So again, not a standardized message, but really focusing the message to these parents that were there at this very small session. And so 6 months after the intervention, parents attending the educational session were more likely to place their infant on their back to sleep, less likely to bed share, less likely to cite infant comfort as a reason for the sleep position, and they're more likely to be aware of position recommendations. And so, again, I'm not sure that kind of all the media blitz surrounding safe sleep, it remains to be seen whether that will make a large difference in our sleep-related death rate. But I think the more personalized the message we can get, and so the work that you are doing one-on-one or two-on-one with families is so important. I think that's when we're going to be better off, and I think that's going to be more effective. I will also say that there was a Brazilian study actually a few years ago that replicated this. Mothers receiving individual education at that time in a similar fashion were 2.5 times more likely to place their infant supine at 3 months of age. So again, moms are listening. It just needs to be tailored and given appropriately. So the health belief model is one's assessment of the personal risk will directly impact the likelihood of adherence to a behavior change. And you all see this. I see this. So we need to provide messages that promote the realization that every infant is potentially at risk. And again, we see this all the time. This couldn't happen to my baby. This will not happen to me until it does. So one city I like to mention as having done this well is Baltimore, and they launched the Be More for Healthy Baby program a number of years ago, and they pictured television ads, and the ads are done by families who have lost a baby with due to a sleep-related death, and they are very moving and they are very powerful. But again, this kind of gets to the fact that's my neighbor. They live down the road. This happened to them. And so I think any kind of peer counseling that can be done through any form or fashion is the way to go as well. Going through one of these other categories of safe sleep intervention, and potentially something that you could try when you're meeting with your families, is kind of going through the culture and the tradition route. And so on this next slide here, I focus on a book that was written for this very issue, and kind of the idea of reading to your children, which I think is a big cultural thing for a lot of families in our state and around the country. So there is a book, you might have heard of it. It is from a foundation called Charlie's Kids, and the book is called Sleep Baby Safe and Sound. And basically it goes through the safe sleep guidelines except in a storybook rhythmic form, and it's beautifully written. It's in English and Spanish. There have been 400,000 books distributed in most of the states in our country in efforts to reduce the sleep-related death rate. And they actually did a study about this book, and it came out at the end of last year in Academic Pediatrics. And so in this study, they enrolled mothers who were deemed to be low socioeconomic status, so poverty rate, not a high level of education. These were enrolled in a home visiting program. And they did safe sleep teaching and assessments during the 3rd trimester, so before moms even had the baby, at 1 week of age at that first visit, and then at 2 months of age. And for half of these women, they utilized this children's book that I just listed, and then the other half were just very standard safe sleep brochures. And so they assessed safe sleep knowledge and usefulness, and then how well were they actually adhering to the practices that they were hearing in these brochures and in this book. So what they found is that safe sleep knowledge increased throughout these visits. There was no difference in the brochure and no difference in the book. And mothers and home visitors both reported they were similarly useful. All the materials were in providing safe sleep education. However, the changes came about in the next slide, and you can see here in this graph, the leftmost column has data that were greater for the book, so the Safe Sleep book, and then this middle column that has greater for brochure underneath it were for the information, the moms that had been taught using the brochure. And so you can see by looking at the dots here on this leftmost column, the greater for the book, that healthcare workers observed more often that moms were using the crib to put their baby into sleep, and the crib was in the parents' room, again, a room-sharing situation. You can also see that moms were more apt to kind of read to their baby using this book, again, which is another added bonus. Whereas for the brochure, there was greater evidence of observed bed sharing, as well as moms reporting more often that they were bed sharing. And so I think thinking outside the box and using different teaching techniques to get the message across could be useful as well. Of note, this book is available on Amazon, so it can be purchased. You can also go to what's called the Charlie's Kids Foundation website and get more information on the book there. So I will also kind of highlight another thing that different communities have done is community-wide themed baby showers. This was started in Kansas, Their Kids Network, which was Kansas Infant Death Network. And so they have, again, done community-wide baby showers focusing on safe sleep. And so expectant mothers will come. They will have some kind of food or meal, and then they will play games and have education related to safe sleep practices. They will either receive a wearable blanket or sleep sack, or they can be raffled off to do this, or a portable crib. But again, they are getting education and modeling and promoting safe sleep throughout that entire baby shower. And so they have preliminarily shown that the data has shown that there has been increased safe sleep knowledge and then the intent to at least practice safe sleep behaviors after parents leave that baby shower. So also promising. So I wanted to end with kind of a more controversial area, but I think you guys will be hearing about it because I certainly have. I don't know how many of you heard about the NPR report or were asked about the NPR report that came out last May on sleeping and co-sleeping bed sharing. I was certainly asked a lot about it. And so this NPR came out. I've listed the link below if you'd like to read about it. And it really talked about an idea that is not promoted by the American Academy of Pediatrics, which is what I will discuss first, but might be a future step for the American Academy of Pediatrics based on the work of other countries. And so this report discussed customizing the risk of bed sharing based on factors such as the term status, whether the baby was full term, preterm, the current sleep environment, different kinds of parental behaviors such as smoking and drug use, etc. And again, these are based on 2 case control studies out of Britain. They were very small sample sizes, however. But again, this might be coming in the future for the AAP. And as we go to the next slide, I will read you some quotations from the last AAP recommendations that kind of support the fact that this might be where they're headed. They do state that the safest place for an infant to sleep is on a separate sleep surface designed for infants close to the parent's bed or room sharing. However, and this is a new statement not put in any of the other previous recommendations, the AAP acknowledges that parents frequently fall asleep while feeding the infant. So next slide. So I want to talk about that a little bit because, again, many other countries have moved from an abstinence-only or don't ever do this to risk mitigation. Specifically, New Zealand and then Britain, United Kingdom, as I mentioned, has been doing this for years, this risk mitigation, and has seen a drop in their infant mortality rates. So let's talk about this. So I know I get in this situation quite a bit, and I'm sure you do as well. With the next slide is what should I do when parents decide to bed share or practice unsafe sleep? Because admittedly, no matter what you do, no matter how well you counsel and no matter what happens, some parents will not agree to practice safe sleep behaviors. And so the question is, what do we do with that? And so here's my suggestions, or here's what I do. And this is actually, in discussing this with the lead author for the Safe Sleep recommendations for the past several years, her name is Rachel Moon, this is what she reports to doing as well. So we educate, of course, we first educate on the ABCs, making sure the parents do truly know the risk and what the best practices are. Counseling appropriately if possible, but meeting them where they are. So not necessarily promoting unsafe sleep practices, but not judging families for it either. Because I think that whenever we judge people or get the perception we're judging people, I think that cuts off communication and the good relationships we're trying to foster with them. So if parents are going to bed share or space share or co-sleep or whatever we call it, this is what I counsel them on. So I counsel them extensively on the risk to preterm and younger infants. So that means this is far more risky to do in your 1 and 2 month old infants than it is in your older kids, so something to think about. Counseling on tobacco, alcohol, and drug use. These are big, big no-nos for families that want to bed share or space share. And so I make sure that that's counseled on heavily. Talking about the importance of breastfeeding, because even though breastfeeding does not erase the risk of bed sharing, it is a protective factor against SIDS. And so I think anything that you can do to help protect is a good thing. So I do counsel on the importance of breastfeeding if parents intend to bed share. It is, strangely enough, studies have shown that it is safer to share a space in an adult bed rather than a couch or chair. There's been an increased rate of sleep-related deaths for babies that have been co-sleeping with parents in the couch or a recliner than there has been for babies sleeping with parents in the adult bed. So that is actually something to consider. Ideally, parents will have no blankets. So parents can wear sweatshirts, slippers, what have you, instead of having those heavy blankets in the crib. Same with the pillows. Throw pillow, little pillow, neck pillow, or no pillow at all, rather than the big fluffy pillows that are commonly seen in adult beds. I know some families that will put toddler rails on the bed to prevent the babies from rolling out if they are in the adult bed. Or some families I've heard of will put the mattress on the floor against the wall so that the baby cannot roll over and become trapped between the bed and the wall, as we talked about in a previous slide. I also know some families that will have mom only in the bed, so no other kids, no other pets. Dad will sleep somewhere else. And again, this might not always be favorable for some families. But depending on how, I counsel on everything, and so I give it up I make sure the parents have the appropriate information that if they are going to bed or space share, this is as safe as we can make it and all the risk mitigation we can provide. So there's a lot of information I just handed to you in the past hour. Thank you so much for your attention. I apologize for all the technical difficulties. Haley did a great job of navigating through all those. If you have any questions in the future, I have listed my email address here. I know that Haley will give you her contact information as well. We would be happy to hear from you at any time if anything comes up.